Thank you once again for having me in this instruction course. I have been asked to present on CFEOM and Mobius syndrome, the surgical management. There are a lot of things to be covered with the evaluation as well, but I will briefly cover. It's a congenital non-progressive ophthalmoplegia, comes under CCDD. It can be with or without ptosis. It can be unilateral or bilateral, depending upon the types. Two nerves are most commonly affected because of the neuropathy. One is oculomotor, second one is trochlear nerve. There is a significant overlap in the clinical phenotypes. So genetic classification is more informative. There are at least 8 genes involved. Basically, it's classified into type 1, type 2, type 3. This is the kind of findings what you will see. In the type 1, mostly the eyes will be hypotropic. In the type 2, it could be mainly exotropic. It does not mean that there is no overlap. Only thing we need to remember is additional finding of retinal dysfunction in type 2 and possible neurological findings in type 3. We have written the whole chapter on this cranial degeneration in Hoyt textbook, Taylor and Hoyt. Autosomal dominant, you can see in this picture here. Type 1 is hypotropic. Mostly they have autosomal dominant type of variety. The type 1 can have exotropia, as you can see here, exotropia as well as hypertropia. The elevation is not usually beyond midline, and there could be a perverted convergence on upgaze. Type 2, additional findings we need to be careful. Retinal dysfunction and pupillary abnormalities. They will be usually exotropic, as you are seeing in this patient here. Type 3, mostly unilateral, but I don't see much of a neurological finding, but in the literature, it's been told that most of them can have neurological. I would present 3 cases of these types. Type 1, you can see large face turn for this patient, 35 degrees with the chin elevation, and he is fixing with abduction in the right eye. Hypertropia with exotropia, you can see in the primary position. You can see his motility wise, there is a large exotropia with hypertropia. And you can see the elevation is defective in both sides. And sometimes measurement is not so much important. We might have to depend on Hirschberg test in these patients. Generally, I get a MRI study done in this patient. You can see on the left side, normal MRI. On the left side, patient's MRI. On your right side is patient's MRI. On the left side is normal MRI. See how thin the muscle becomes. The primary pathology here is not in the muscle, it's in the nerves. But because of hypertropia, there is atrophy sets in. You can see other than bulky superior oblique, all the other muscles are thinned out. Because of that bulky superior oblique, they can also have hypertropia in this patient. There are some challenges in surgical management. First one, it's a fibrotic or paralytic muscle with aberrant innervation. They do not follow any laws of innervation. No specific rules for surgical thing. One of the thing here is most of them don't have binocularity. It's only we are trying to correct the abnormal head posture. They may not have a very much distorting torsion. It's always good to go for a staged surgical approach. And some of the pearls you need to remember while you do surgery is, as you can see, superior oblique insertion is nasal. This can happen in type 1 CFEOMs that are already published. This is one of our patients. You can see anomalous, tight superior oblique with thin or hypoplastic. This is one of the known things. So it can, superior oblique anti-transposition can help in some of these patients with the supra-large recession and resection. KIF2-1A patients require profound weakening of IR, that is in type 1. You should always have a counter traction for these patients, and fibrotic bands are not very uncommon, and you need to always do a FDT before. And in this patient, we did a very large recession on the right side with resection. Other side, we did a periosteal fixation with a very large. This is like nystagmus management. You can go beyond the normal number what you do, and along with that, superior SOAT has been done. And this is the post-operative picture. As I said before, you can't make it perfect, but we can make a little bit improvement, maybe 60% improvement in this patient. And this is another patient. You can see she has a chin elevation, chin up position with the face turn, with the large esotropia and hypotropia here. We did a very large MR recession on both sides with the left inferior rectus recession. This is her MRI. We always try to do an MRI when possible. It's not a must, but some patients we need to do it. And it's also neurologist can look at the 6th nerve, 4th nerve, and 3rd nerve. And this is post-operative after MR recession and IR recession in the left eye. She has a significant improvement in both in alignment as well as abnormal head posture. You can see in this patient. And this is the last one case with the kind of mixed features. This patient had ptosis with large esotropia with tight muscles, with the correction of the esotropia as well as doing inferior rectus recession. His ptosis also disappeared after doing this surgery. Most of this based on these patients, based on your FDT findings. There are two things which can help is genetics as well as MRI. But your surgical dose, at least what I do is I will keep it in a relaxed position. FDT based surgery is what I try to do in these patients. Mobius syndrome, I treat them. They have a abduction limitation bilaterally. They have lag of thalamus. They will have significant abduction. They behave similar to Duane syndrome, which is bilateral in terms of, I'm talking about in terms of surgical approach. And if you see Dr. Luder, he had one of the large series where he says a large MR recession is a good idea in these patients. This is what he had 5 patients with the long-term outcome. They did well over a period of time. That's one of the approach. Recently, what I do is I do a bilateral SRT in them along with MR recession, similar to what we have done for this bilateral Duane syndrome. You can see alignment as well as improvement in their abduction. That's what is surgical management. Otherwise, they just behave very, very similar to bilateral Duane syndrome, that is esotropic. Usually, they don't have any kind of fibrotic band or anything. So in terms of take clinic message, due to the nature and rarity of this disease, surgical treatment poses a great challenge to all of us. Investigating for associated neurological abnormality is important. Genetic counseling, it is difficult to get for every patient, but if you do it, it's important. We need to always go for realistic counseling because patients have a lot of expectations. But in spite of this, we might have to do more than one extraocular muscle surgery. And this improves their quality of life, as you saw in the abnormal head posture correction in these 3 patients, not a perfect alignment. Some of the comitant strabismus, nowhere we can kind of counsel for perfect alignment. But in these cases, we have to be particularly careful. Thank you so much, Dr. Sharma and AOS for this opportunity. I stop sharing here. Thank you so much.